catheter mitral valve repair on behalf of the International Registry Committee for the Cutting Edge Registry. It's important to acknowledge that after 17 years of evolution, iterations, and several studies, randomized controlled trials, but also observational prospective studies, there's still an unmet need in terms of treating percutaneously mitral regurgitation using edge-to-edge technology. It's a very effective therapy. It's very helpful for the patients, but it's still unoptimized in some subcategories of patients that we have to address. This is reflected by STS national database registries, where it shows clearly that despite continuous evolution and progress in terms of techniques and also the technology itself, many patients remain with mitral regurgitation, moderate to severe, but also high gradients above 5 millimeter mercury. And despite the selection a priori of these patients, the consequence in terms of mortality is high, and that during the hospital itself, but also at 1 month and at 1 year, where the rate could sometimes double. So the question is, despite all the improvements, there are still unmet needs, and all patients does not match the results that we have from COAPT for functional mitral regurgitation, neither from expand registry. So after 100,000 transcatheter edge-to-edge mitral valve repair that has been performed worldwide, some patients still in unmeeting the needs of treating this pathology. And there's a lack for multi-institutional longitudinal data on mitral valve surgery itself. This is why this multi-center registry was initiated by a group of colleagues and friends from all over the world, and which we invite you to join as soon as you can. So the patients that we have been collecting have been divided into 3 groups: aborted cases, aborted MitraClip cases, aborted acute referred to surgery after edge-to-edge repair, and separate admission, which means staged or planned surgery after failure of MitraClip. MVARC2 outcomes at 1 month and 1 year were evaluated. Median follow-up was 20.9 months from the date of edge-to-edge repair. In 15 years, we have been able to include in this initiated registry 173 patients from 18 different centers with mean age of 73. So they are quite young, actually. Median STS risk score was 5.5. 51.5% of the patients were treated using the original MitraClip device, and the others with the different iterations that appeared to date. Patients had degenerative but also mixed disease, which was present in 61.7% of the cases. Median interval from date of transcatheter edge-to-edge repair to surgery was 4.8 months. Of course, there was some variations depending on if the patients were in the aborted group, acute group, or the delayed, which was the biggest subgroup. Surgical indications were partial or total leaflet detachment, recurrent and mitral regurgitation, which means failing to treat the mitral regurgitation completely, residual MR, of course, and some patients had mitral stenosis, which is not a very small number, as you can see it here. Mitral valve replacement was performed in 90.6% of the cases, and we had to almost replace the valve in to repair the valve. We could have been able to repair the valve in around 10% of the patients. So unfortunately, when if MitraClip fails, the majority of patients would go for mitral valve replacement. This is an item to keep in mind. In more than 40% of the cases, because we have been doing surgery, we achieved concomitant mitral tricuspid valve repair. Mean cardiopulmonary bypass and our aortic cross clamp was higher than average and usual practice, that these patients were a bit more difficult to treat. 1 month and 1 year mortality were respectively 15 and 26%, which is very high. Updated data and analysis will be presented here this year for the first time. at EACTS, which I'm proud to do so. So these are the echographic characteristics, as you can see it here, that the majority of patients, of course, had moderate to severe and severe mitral regurgitation here. So patients were operated with failure to treat mitral regurgitation. They had impaired left ventricular ejection fraction. Few of them had moderate to severe and severe tricuspid regurgitation. So this feature did not really was not of big influence on the outcomes, and also few of them had moderate to severe or severe right ventricle dysfunction. So this right heart pathology was not really a major or a game changer in terms of interpreting the results. We have been able to treat after surgery to tackle the mitral regurgitation, and as you can see it here, the majority of patients had no mitral regurgitation after the surgery itself, which is the target and that we wanted to achieve. And again, the majority of patients also did not have tricuspid severity despite the cross clamping and the cardiopulmonary bypass. The surgery did not worsen either the right ventricle dysfunction that has been present or not before the surgery itself. So surgery didn't have direct impact on tricuspid or valve regurgitation or right ventricle dysfunction. This slide illustrates clearly the impact of surgery in this category of patients on survival, and you can see it here that overall survival after mitral valve surgery was at the latest follow-up of 69.5%, so almost more than 30% of the patients died during follow-up. And of course, there was a higher mortality in the functional mitral regurg group in comparison with the degenerative mitral regurg group, which is very important to note. So this slide, it's a very bit heavy. It just clearly shows that predictors for 30 days were mainly COPD, frailty, chronic kidney disease before MitraClip and index surgery, which is the acute group. Of course, there was a difference between degenerative mitral regurgitation and functional mitral regurgitation, and only bleeding, major bleeding, was a predictor of mortality in the group of FMR. And this is also important. Maybe these patients were a bit more fragile, I would say. We need more patients to be included, of course. This is a very introductory results, I would say. It just shows that it's not always easy to achieve a surgery after MitraClip failure, and our duty and responsibility is to evaluate in order to see how and what we could improve within the confinement of a heart team. And I think this heart team discussion is very important to do a priori, and being able in the future with accumulated data and increased experience from this group or that group, and be able to offer to the patient the best that we could. So in the conclusion, I would say this is the first report of Cutting Edge Global Registry, to which we invite you again to participate. You can contact any of the members of the committee, and we're happy to integrate your results. It provides a good opportunity for further in-depth studies of this patient population. It's very important to know that this is the take-home message, that the risk of mitral surgery after transcatheter edge-to-edge repair is non-trivial. Nonetheless, it provides valuable data for further research to improve these outcomes. Thank you very much.
Thomas, thank you for this excellent presentation. And welcome to the questions. I see no questions from the floor so far, so maybe I can start. It was surprising that you had no single endocarditis case in your series. One should expect, if you see big TAVI registries, that single endocarditis cases should be there. Or did you exclude those?
No, there was no. So thank you, Matthias, for the presentation. I think this is a very important topic, and again, we should situate it in the confine of heart teams. So, as I said in the beginning, this is just initiated study that and data were collected in a very few time, and we didn't meant to exclude any patients. The only thing is that we have been limited by the number of participant centers, 18 centers from all over the world, 10 in US, 6 from six from US, from Europe, 2 from Canada, and I am sure that this is underestimating the number of patients that we could have been able to include, but also those who had mitral endocarditis. So it was not an exclusion criteria. It was just not captured by this study at this level of the investigation, I would say. But I agree with you. We should look at it because the mitral regurg, especially if it's chronic, it's a risk factor for endocarditis. But you can see it here also that although the surgery was delayed in the majority of patients, there's still a consistent number which were operated on acutely, and these patients were also strictly followed, and probably they have been better supervised, I would say, in those that have been included, and probably because of this, they had less rate of endocarditis, which again was not captured because of the design of the registry itself.
Matthias, may I ask a question to Thomas? Maybe from the cardiology point of view, because I hope that many cardiologists are online to watch this insightful data. And Thomas, my curiosity is about 90% of replacement. So my question is, when you are in front of a failed edge-to-edge transcatheter repair, is it because repair was not a good option in general for that patient, or because technically there was no annuloplasty on top of the edge-to-edge repair, or is simply because the transcatheter repair failed in that patient? Is it the concept or the technique, in your opinion?
David, this is a very important question, and I'm happy that you asked this. I mean, it's obvious more a cardiologist question. I mean, so let's look at the population that we are addressing here. So the majority had FMR, as you could see it. And in FMR patients, once you have clipped, the leaflets are thinner. You almost exclude all possibility of repair, because the best that you could do, because that is to annuloplasty again. But if you want to do an annuloplasty, you need to have normal leaflets which can coapt again. Of course, you can add papillary muscle, string, or many other techniques to but this is not the case here. So for FMR patients, one, you have provoked lesions of the leaflets. It's almost impossible to do a good correction of or reparation of repair of the valve. In degenerative mitral valve patients, it also depends on the finding during the surgery itself. And again, once you will have to exclude some segments of the valve. It depends on which segment is attached. It will also be very difficult to achieve a good repair of the patient. And the one important feature also to keep in mind that you could have seen it, the length of the surgery itself was longer than the cramping is longer in a very fragile population of patients. So the idea here is to do the job as good as you can, as quick as you can, and leave the room. So, I mean, very humbly, I would say, it's from anatomical point of view, once you have provoked some lesions for the leaflets themselves, it's very difficult to achieve a good repair. This is what we have to keep in mind, and the message we want to share with our colleagues from cardiology heart team, I would say, contribution.
Thank you, Thomas.
And finally, I can only congratulate the group of surgeons performing this operation, because you achieved remarkable results. The first decline in the survival curves is, of course, owing to the sickness of the patients. But if you start in the survival curve after this 20% loss of patients at half a year, you get quite a good survival for the rest of for the 80% survivors. That is a remarkable achievement, and also compares very well to COAPT and Mitral FR.
Exactly. And Matthias and Davide, I mean, if you allow me just one final remark. Again, the objective of this work from all the team that initiated the study is not to say edge-to-edge repair is bad. It's just to say that we should work together in the confinement of a heart team and try to see or figure out what is the best indication for patients. And hopefully we want to continue this registry, and we are really, again, this is an open invitation for everybody to join us. And probably in the future, having more data and have a comprehensive approach, we will be able to refine and better selection and to achieve the population. This is the main idea behind this study.
Thank you, Thomas. But we need to move on. That was an excellent presentation.
Thank you very much.
Okay.
Thank you. Now we go. Bye-bye. Good.
Bye-bye. We go on with the next presentation coming from Munich, Dr. Vitanova. It's again a very good example of a functioning heart team where it concerns the explant TAVR International Registry. So please.
Dear Chairman, dear colleagues, dear ladies and gentlemen, it is an honor to me to present the data of the first international registry about surgical explantation of failed TAVR prosthesis. TAVR procedure is nowadays well established not only in patients at high operative risk, but considered equivalent or superior to surgical aortic valve replacement in intermediate risk patients. Consequently, increasing use of TAVR in intermediate and even low-risk patients can be expected. So the surgical explantation following transcatheter aortic valve replacement may be necessary in patients requiring valve reintervention. While evidence on safety and clinical outcomes after TAVR is expanding, less is known about the outcomes after their surgical explantation and subsequent TAVR. What actually do we know? For example, Fukuhara et al. Published a large single-center study of 1,400 patients and 1% explantation rate. They reported about in-hospital mortality of 12%. This big population-based study showed similar mortality of 13% after 30 days and a high hazard ratio of 4 for the surgical explantation group. In order to get further in-depth studies of this patient population, all these 37 centers from North America and Europe put together their data and formed up the International TAVR Explant Registry. From January 2010 and June 2020, a total of 198 patients across 37 centers were included after surgical TAVR explantation. Endpoints were the VARC-2 criteria at 30 days and at 1 year. All patients who underwent a TAVR explantation during the same hospital admission were excluded. These were the baseline characteristics of the patients. Mean patient's age was 72 years and the baseline characteristic did not differ between both groups with exception of the variable frailty, which appeared more often in the European patients. At index TAVR, mean STS risk score was around 5 and about 29.4% of the patients were deemed low surgical risk. These were the indications for surgical explantation and included endocarditis in 38%, structural valve degeneration in 24%, paravalvular leak in 17%, prosthesis patient mismatch in 7.4%, and valve migration in 3.7%. Endocarditis was more frequently the reason for explant in the European group compared to the North America group. There was no significant difference regarding the other indications for explant. Balloon expandable and self-mechanical expandable valves were evenly distributed and accounted for 50 and 49%. The median time to surgical explant was 12.8 months, and root replacement was performed in 60% of the cases. About 45% involved then concomitant cardiac procedures. We found an in-hospital mortality of 12%. In Europe, the patients stayed longer in ICU and in the hospital. In-hospital complications included atrial fibrillation in 10.6%, new pacemaker in 13%, and acute renal failure in 7.9%. All complications were not significantly different between both groups. 30-day readmission rate was higher in North America than in Europe. There was no significance in the other short and midterm outcomes. Overall survival of the patients at follow-up was 72%, and there was no significant difference in the survival between both groups, patients from North America and Europe. These were the univariate predictors for all-cause mortality. Frailty, diabetes, chronic kidney disease, pulmonary hypertension, and life-threatening bleeding were univariate predictors of 30-day mortality after TAVR explant in the cohort. Predictors for 1-year mortality were chronic kidney disease, vascular complications, major bleeding, and AV regurgitation. We can conclude that minimal regional differences between North America and Europe were addressed to the indications of explant, hospital stay, and in-hospital complications. However, these all had no influence on the survival rate after TAVR explantation. 16% of the patients needed a concomitant root replacement at time of explantation, which is an important point to discuss the feasibility of the surgical explantation. More than 80% of the patients had at explantation at least intermediate or high risk, so we can conclude that survival rates of 77% after 12 months and 72% after 36 months are very valid. Thank you to all who joined and contributed to this registry, and thank you for the wonderful collaboration. Here you can see the context if you want to participate also in this project.
Thank you. Thank you very much. Welcome, Dr. Vitanova. Thank you very much for sharing this important data. This is a registry I'm sure we will hear more and more. And your call for more data, for more centers participating was very appropriate, because the bigger the data set, the higher the power for all the analysis that you have to conduct, including looking for predictors. I have a question for you, if I may. I was interested by the rates of the admission that are a little bit higher in the North American sites as compared with the European sites. Do you have an explanation for that, or is it play of chance?
First, hello from Munich. Can you all hear me well?
Yes, very well. Thank you.
I would first start. I would like to apologize for my terrible talk right now. It was a pre-recorded version, and I was sure this is just a backup version. So I'm going to present now live. Now you all saw it.
Very good. It was very good. Don't worry.
I think going to your question, I think it is depending on the hospital stay and ICU stay in US. In America, we know that there is another politics, another organization. And if the patients who are critical ill with high STS score are going too early at home, I think that's the one reason for the readmission. Second reason could be because in Europe are more organized or pre-organized rehabilitation after a big surgery. I think that is everything to do, or mostly, with the health management system.
Okay.
A very nice presentation. Indeed.
Well, thank you.
Well, you found, not surprisingly, very few differences between Europe and the US. But for me, a little bit surprising is that you have more endocarditis in Europe, the percentage is higher, and you have faster surgery. Cross-clamp time was quicker.
Yes.
Did you find some clues in the data to explain that?
Not at all. I have no idea why are the surgeries, the aortic cross-clamp, faster in Europe. Knowing that most of the patients are coming from North America in this registry, and so 2/3 to 1/3 in from all patients in this sub-analysis, it could be subregional differences from smaller centers in North America. And about the endocarditis, I'm not pretty sure why is it more in Europe. I think the policy for antibiotica, it's quite same in North America and Europe. It could be, one reason could be that in North America, to my acknowledgement, is that first diagnosed TAVR endocarditis, it always first preferred to be medically performed with antibiosis, and in Europe, if we see a prosthesis endocarditis, so we are doing a surgical approach on a first line. We don't even try to beat it with antibiosis.
May I ask one additional question? I know it was not the main focus of your research, but can you find from the data in the registry outcome data on self-expandable versus balloon-expandable valves? Is there a difference in outcome? Because the surgery, at least to my experience, is quite different.
Yes, I think I understand what you mean. We still don't have the whole sub-analysis done, but we are planning to do balloon-expandable versus self-expandable valves. To my experience, the 3 cases that I did by myself were 2 self-expandable and 1 balloon-expandable. I think that the balloon-expandable is more difficult. And adhesions are not only valve depending, sometimes this depending on the time, how long the valve is inside. I don't know, how do you see on this issue? The registry data showed about 16% aortic root replacement concomitant to the procedure, which is not a quite low number.
Yeah. That is true, but your data also shows us that the surgery post-TAVR is safe, and well, even though the population is sick, we can offer a good solution in those severe circumstances.
Yes, it's actually very feasible and technically surprisingly better to do it than expected.
Thank you. In the interest of time, we have to move on.
Okay.
Thank you again for the opportunity. Thank you.
Thank you, Dr. Vitanova. So I just remind our audience that they can send questions through the chat. They can also use the official hashtag of the Congress, hashtag EACTS 2020. So we are happy to take your questions. And now we can move to a series of featured lectures. And the first one is about transcatheter technologies. The title is provocative, of course, embrace, but be wary of the creep. And the presentation will be by Tom Nguyen from Houston, United States.
I'd like to thank the association for the privilege of discussing two late-breaking and landmark trials by Dr. Villanova and Dr. Modi, and I want to applaud them both for an excellent presentation. The theme of my presentation will revolve around transcatheter technologies and the importance for us as surgeons to embrace the technology, but also to be wary of creep. These are my disclosures. But probably the most important disclosure is that I'm a minimally invasive valve surgeon. I enjoy doing complex operations through small incisions, but I also appreciate the value of transcatheter technology and enjoy working in a cath lab with my cardiology colleagues. We're now in a new era of TAVR. This is Mick Jagger, 6 weeks after having a transcatheter aortic valve replacement. I would argue that few patients who under either sternotomy or a minimally invasive aortic valve replacement can dance like that at 6 weeks. We're now operating on not only septenarians, octogenarians, nonagenarians, but also centenarians with very good results. This figure shows the growth of TAVR as a function of time. And in 2015, TAVR exceeded isolated aortic valve replacement. And later in 2019, TAVR exceeded all forms of aortic valve replacement. This figure shows the growth of mitral clip technology. And as you see, this also showed explosive growth. There have been more than 100,000 mitral clip implants worldwide. So it seems pretty clear that transcatheter valve is taking over surgical valves, right? That's why I want to pause a little bit and stop, and I don't think that's the case. In the next series of slides, I'd like to explain why. As surgeons, I think it's important for us to know the data. And in some ways, I think we need to know the data better than other people in the room. And it's only if we know the data can we know the limitations and have productive conversations. So in this talk, I'm going to summarize what we know and what we don't know about transcatheter valves. And then I'll tie it to the consequence of creep as it relates to Dr. Modine and Dr. Villanova's presentation. Let's start off with TAVR. And here's what we know. In 1995 was a TAVR patent by Dr. Anderson. 2002, the first TAVR in man by Dr. Alain Cribier. 2010, the PARTNER 1B trial. These are patients who were inoperable. They were randomized to either TAVR or standard therapy. Nearly 25% reduction in mortality at 2 years. There's improvement in quality of life. Stroke rate was high, 13.8% for TAVR versus 5.5% for standard therapy at 2 years. Vascular complications were higher in the TAVR arm, 17.4%. In 2011 was a PARTNER high-risk trial. These were patients who were randomized again to TAVR versus SAVR. All-cause mortality showed that it was non-inferior at 2 years. Stroke was again higher in TAVR at 7.5%. Vascular complications were higher in TAVR at 11.4% versus SAVR at 3.8%. The PARTNER 2A trial looked at patients who are intermediate risk. These patients were again randomized either TAVR or SAVR, also included in an alternative access arm. The average age was 81 years old. The average STS score was 5.8. When we're looking at TAVR, both transfemoral and TAO and TA show that TAVR was non-inferior to SAVR at 2 years. In the transfemoral group sub-analysis, TAVR had a lower mortality than SAVR, a mortality and stroke than SAVR at 2 years. The PARTNER 3 low-risk trial, 1-year result, was published in 2019. Again, a randomized trial looking at patients who are low risk. The average age support was 73 years old. The average STS score was 1.9. Interestingly, the primary endpoints were mortality, stroke, or hospital rehospitalization. As you can imagine, TAVR had a lower primary endpoint at 8.5% versus SAVR at 15.6%. And it's also interesting to note the sub-analysis showed no difference in death between TAVR versus SAVR. The PARTNER 2A intermediate risk results at 5 years were presented in 2019 by Dr. Vinotharani. What's important about this figure is in the first 1, 2, 3 years, there was not much of a difference, but after 3 years, we begin to see the curves start to diverge. And the reason why this is important is that as we start moving, these trials start to move to lower risk cohorts, I think we need long-term follow-up because that's when events start to happen in these lower risk patients. The PARTNER 3 2-year results for low-risk patients presented in 2020 at the ACC by Dr. Michael Mack, and the results were still favorable for TAVR, but not as significant as it was at 1 year. TAVR is still non-inferior to SAVR at 2 years, but the main difference was due to a significant difference in rehospitalization. This is not discussed much, but in this trial here, it showed there was an increased incidence of death, stroke, and valve thrombosis in TAVR versus SAVR at 2 years. Again, we begin to see the primary endpoint, the curves start to converge. So there was less of a difference between TAVR and SAVR at 2 years in patients who are low risk. So again, I think as we move to lower risk cohorts, we need longer term follow-up because that's when the events start to happen. Let's change gears a little bit. I want to now focus on what we don't know and some potential limitations. I know this slide is relatively busy, but these are the conversations that we need to have in the hallways and in the water coolers. First, it's important to note that all the TAVR trials, all the randomized TAVR trials so far have been industry sponsored. We know the randomized control trials are the gold standard, but it only applies to the study population. There are strict exclusion criteria. So for P3, there are 31 exclusion variables. Core valve had 17% of patients excluded, 34% of patients screened out. For patients who are low risk, we only have 2-year results, and it's impossible for us to extrapolate the outcomes in patients who are low risk beyond 2 years. The average age of the patient in the lowest trial was 73. So the reason why that's important is in a patient that's 64 who's low risk with severe aortic stenosis, we don't have more than 2-year follow-up comparing TAVR versus SAVR in a randomized controlled trial. Concomitant surgery in TAVR, 7.9%. In SAVR, 26.4%. Primary endpoints was interesting. It was death, stroke, or rehospitalization. And as you can imagine, in a patient that had a SAVR mitral or a SAVR CABG has a potential to have a higher rehospitalization rate than a TAVR patient who had a PCI. It's also important to note that in the low-risk trial, bicuspid patients were excluded, but the FDA approved TAVR for bicuspids in low-risk patient populations. So again, in that 65-year-old patient who's low risk with severe aortic stenosis and has a bicuspid aortic valve, we had absolutely zero data comparing TAVR versus SAVR in that patient population. PVL mild to greater, 29.6% in TAVR versus 2.9% in SAVR. It's important to note as we're doing this in younger and younger patients, TAVR is more difficult to perform coronary interventions, whether that be PCI or stents. It's unclear about leaflet thrombosis in the P3 sub-study. TAVR is greater than SAVR, greater than 20% of patients had HALT at 1 year. We can't forget about basic class 1 indications. If a patient has multivessel coronary disease, diabetic, they need a CABG. We know that it has a survival benefit. At our center, SAVR has a larger profit margin. We can't forget about that as well. So changing gears a little bit, I want to talk about MitraClip and focus on what we know and what we don't know. The first MitraClip patent was in 1997. What was interesting was that 2 of the people on patents were surgeons, Dr. Oz in the United States, as well as Dr. Juan Umana in Colombia. An interesting bit of trivia, the first MitraClip patent was via a transapical approach and not via a transeptal approach. 2003 was the first MitraClip in man. 2005 was a phase 1 clinical trial looking at MitraClip. There's an Everest trial. 27 patients, 18 patients free from surgery at 6 months. Here's another way of looking at it. 9 patients, or 33% of patients, required surgery within 6 months. Follow-up was only 6 months. 64% of patients discharged had less than 2+ MR. Here's another way of looking at it. 36% of patients at 6 months had 3 to 4+ MR. That's not inconsequential. The Everest 2 trial is important to discuss, and this is important because this was the very first and actually only randomized controlled trial looking at clip versus surgery. 27% of patients had prior surgery. The study included FMR and DMR. MR at 5 years, patients had 3 to 4+ MR at 5 years. 12.3% of MitraClip patients, 1.8% of surgery patients. Mortality was roughly the same. The authors conclude that surgery is more effective at reducing MR, but MitraClip was comparable to surgery in improving remodeling. Again, this is only randomized controlled trial comparing MitraClip versus surgery. COP trial is another important trial. Moderate severe MR, 100 sites, MitraClip versus medical therapy, prohibitive risk patients had an STS score greater than 8%. It's a highly selected group. 63% of patients were excluded. 61% required more than one clip. The mean ejection fraction was 31%. The left end diastolic volume was 101. Mitra FR, severe MR, a lower number of sites, 37 sites. MitraClip versus medical therapy in high-risk patients. What's interesting, this study was funded by the French government, and it showed no difference in death or rehospitalization at 12 months between MitraClip in medical therapy. 32% of patients excluded. The mean ejection fraction was 33%. So it's also important to know the limitations. All the MitraClip studies it's actually really only one, were industry-sponsored except MITRA-FR, which demonstrated some conflicting results. There's only one randomized controlled trial comparing MitraClip versus surgery, that's Everest 2 in high-risk patients. As for some perspective, there's more than 7+ randomized controlled trials comparing TAVR versus SAVR. Despite TAVR and MitraClip emerging around the same time, there's a paucity of randomized controlled trials for MitraClip. The longest follow-up from a randomized controlled trial that we have for MitraClip is 5 years, and that's from Everest. So again, this is important as we start considering MitraClip in younger patients. Everest 2 did not randomize patients to mitral valve repair. Surgery included both mitral repair and replacement, and we know that these are two different populations. For Everest 2, the mean number of clips per center was 5, and the mean number of surgery per center was 2.5. So there's a possibility that a lot of the sites where patients underwent surgery were performed by low-volume mitral surgeons. So let's move to the explant data presented by Dr. Thomas Modi. And this is the summary. 37 centers, average age 72, average STS score 4 to 5%, low-risk patients 21 to 51%, 15% of patients had aortic root replacements, 42 to 51% had concomitant procedures, in-hospital mortality 9 to 16%, permanent pacemaker 13%. My concerns include the following. The patient's low STS score and low risk population, this represents potential creep into the younger population, and we need longer follow-up in these patients. 15% of patients had root replacements in an intermediate or low-risk cohort where they may not have needed a root replacement had they actually undergone a SAVR to begin with. A high number of concomitant procedures, 42 to 51%. Why did these patients not have a concomitant procedure from the get-go if they were to just undergo a SAVR? In-hospital mortality, this is actually very important, was higher than the initial STS score. In-hospital mortality was 9 to 16% in patients with an initial STS score of 4 to 5.6%. High number of permanent pacemaker. The Cutting Edge Registry looked at MitraClip presented by Dr. Villanova, and these are my concerns. Again, patients had a low STS score and low risk population. Again, it's creeping into a younger population for MitraClip, which is only approved for patients who are high or prohibitive risk. There's a high number of mitral replacement in a low risk DMR cohort. 90% of patients underwent a mitral valve replacement if they had a MitraClip explanted. Again, a high number of concomitant procedures. If these patients need a concomitant procedure, maybe they should have undergone a surgical procedure from the get-go. And again, what's very interesting and important, there's a high in-hospital mortality, and it's higher than the initial STS score. So as we go full circle, I want to show the slides of the explosive growth in TAVR and MitraClip as a function of time. And it's increasing as there's an increasing number of TAVRs and MitraClips in low and intermediate risk patients. We need to remember the longest follow-up we have so far is 5 years. There's only one randomized controlled trial comparing MitraClip versus surgery. Both technologies are increasingly being performed in patient populations where we have very little data. We know that explaining TAVRs and MitraClip is not an easy process. So in conclusion, I think it's important for us to embrace transcatheter technology. It's here to stay. We now live in a world of wires. It shouldn't be surgeon versus cardiologist. It should be surgeons and cardiologists in doing what's best for patients. We need to know the data. We need to work closely with our cardiology colleagues. And we need to be very cautious against creep. We need to know the data. We need to know the limitations. We need non-industry sponsored trials. We need to be incentivized to treat patients and not generate RVUs. And ultimately, we need to do the right thing. Again, I want to thank the association for the privilege of discussing these very important papers and also try to highlight what we know and what we don't know and some of the limitations in TAVR and MitraClip technology. Thank you for your time.
Perfect. Tom, hello. Welcome.
Hello. Thank you.
That was a very nice presentation and a run through a lot of trials. Excellent. Tom, let me just start with so one thing that I'm interested in your data that you showed. You showed that halt is more often in TAVR. Why do you think that happens? And is that, well, the first step of a structural valve deterioration, which we see later on?
Thank you, Dr. Seep. And again, thank the association for the opportunity to discuss these very important late-breaking trials. I agree. I think the main point is that we don't know a lot about TAVR in the long term, and we're beginning to find out a lot of newer things. And as we found out with HALT, there is a higher incidence of HALT in TAVRs. I don't know the long-term consequence of that, but there is a potential consequence of that. The etiology of it could be multifold, and perhaps the etiology is that you put a valve and you crimp it down and you expand it with the balloon. That could affect the leaflets, and that could promote more kind of structural irritation for platelet aggregation and subsequent kind of thrombosis formation. I don't know, but I think the key thing, and I guess the point of this talk, and I want the take-home point is, first, I want a disclaimer is I'm a surgeon. I love doing surgery, but I also appreciate and enjoy doing transcatheter work. And I think as surgeons, we need to embrace it. And as we use this technology into lower risk patients and intermediate risk patients, it's so important that we have long-term follow-up, because all the things that you mentioned, whether it be HALT, whether it be survival curves or whatnot. So we need to be very careful and know the data. And in some ways, again, another take-home point is as surgeons, we need to know the data better than everyone else in the room, because we need to, because we have experience from both sides. We need to know the data. And I have to admit, a lot of surgeons don't know the data. They're very quick to refute and discredit the technology, but they don't know the data. So I think we need to know the data. And I think that's really, really important.
Thank you. I think as a cardiologist, I totally share this message that we want to know more about the procedures that we offer to the patients. And I think the ART team must be informed about the pros and cons of each procedure. And surely one of the things we want to know about TAVI is long-term data, especially in lower risk populations and younger patients. So of course, I have no problem in sharing your conclusion. And I think your talk was very balanced in that respect. Maybe the only thing a little bit disagree is about the fact that we don't have sponsored trials, because we have Notion, but we can say it's a small one. We have a UK TAVI now, but we have only 1 year follow-up. So I think we are going in the direction that you correctly mentioned, that we have some replication of data, and of course we need longer term follow-up. But I have one question, if I may, and I take the opportunity, of course, you are from the US, and maybe next month, you will have the new guidelines for valvular heart disease in the US. Of course, I don't want to ask you what you expect, but maybe what is your opinion, and where would you frame TAVR for low risk, intermediate risk, and high risk patients? Or what do you see as the position of this technology given the current data?
That's a great question. You know, so let's focus on TAVR. Right now, we know that TAVR is FDA approved for patients who are low risk. So someone could come in who's 50 years old, 40 years old, with an STS score of 1, and they can get a TAVR, and it's FDA approved, right? But I think the more important question is that we need to have an honest conversation, a very shared decision-making conversation with the patient, the cardiologist in the room, the surgeon in the room, and again, going back to the data and present the data to the patient and let them know the pros and the cons, and be very transparent with what we know and what we don't know. So I try to highlight it in my talk, but the average age for patients in a low-risk trial was 73, 74. Bicuspids were excluded. So a patient that comes in that's 60, that's bicuspid, we have zero randomized controlled data comparing that TAVR patient versus a surgery patient in a randomized controlled fashion. And let's think about follow-up. You know, for follow-up for that low-risk patient, we only have 2-year data for follow-up for a low-risk patient. That's P3 data. For intermediate-risk patient, we only have 5-year data. And I'll also add a little bit, you know, with the subsequent studies that Vino Thrani presented, Michael Mack presented, with the intermediate-risk data, those curves start to diverge a little bit. So, maybe TAVR again is a great technology, but we need long-term data. It started to diverge. In the P3 study that Michael Mack presented, the curves, the differences in TAVR and SAVR started to converge. So there's less of a difference between TAVR and SAVR. So again, to answer your question, if a patient wants a TAVR, they can have it done in the US. It's FDA approved, but I do think we need to have very honest conversations to weigh the pros and cons of both. One last comment, human nature, we tend to strive for kind of short-term gain, whether people invest in stocks and whatnot, people always want the least invasive way possible, thinking about the short-term gain, but we need to change that a little bit because we need to, sure, TAVR, you'll be in the hospital one day, maybe 2 days at most. You do a surgical AVR, you'll be in the hospital 3 or 4 days, but most people want TAVR because you're going to be in the hospital for 1 or 2 days. But we need to change things a little bit, and especially in that younger patient, realize that, hey, it's a marathon and not a race, right? We need to think 10, 15, 20 years down the line for TAVR and for mitral technologies as well.
Thank you.
Yeah, from the discussion with our patients, we know, well, from the discussion with our younger patients, we know that they think in these 10, 20-year or even longer lines. So for them, the discussion about durability really matters. One other point that I want to ask you is, you mentioned that the gaps in knowledge, and especially the gap in knowledge around the bicuspid aortic valve. Why do you think there is this gap? Is industry not interested? Is it too risky? In reality, a lot of bicuspid valves are treated with TAVI. So what is your opinion about that?
Well, I think it's hard to guess the rationale for bicuspids being excluded, but it certainly makes sense in the trials to exclude the bicuspids during the initial trials, the randomized trials, because you want to compare a relatively homogeneous population. And I think that potentially having bicuspids could muddy the water a little bit. So that is a reason perhaps why the bicuspids were excluded initially. But again, we need to recognize that as a caveat. There is a notable paper that came out in JACC a couple of months ago that looked at TAVRs in bicuspids, and the results were very surprising. And I think many of you know. So again, essentially what the results show were that in patients who are bicuspid, who had significant calcification along the leaflets and significant calcification in the raphe, the long-term mortality actually was not that good in TAVR. So again, I can't comment on why the bicuspids were excluded, but in the study design, certainly it makes sense, to exclude it, to make the study population a little more homogeneous. But again, we need to recognize that as we try to adopt that technology in patients who are bicuspids, and especially in patients who are younger. I'm not saying it's wrong. I think we just need to have an honest conversation.
Okay, maybe we have just 1 minute for another question, because we talked a lot about TAVI. We didn't talk about the other part of your talk, which was very informative about the mitral, where the unknowns are even more probably. And maybe my question is whether you see the indication for mitral valve repair, transcatheter mitral valve repair as a whole, or would you separate the indications for mitral FR-like patients and coapt-like patients? What is your view?
Wow, so I'm not sure if I can answer that within 1 minute. I have a lot to say about that. Right. I think the first comment I think is that, I learned this from Steve Bowling. We say MR kind of loosely, that term, but there's primary MR and there's secondary MR. And if you have a primary problem with the leaflet, you fix the leaflet, the patients do well. If you have a primary problem that's a ventricle, the papillary muscle, and you fix the leaflet, the patients actually don't do well, the secondary MR type. So I do think it's so important for us to really separate primary versus secondary MR, especially when we start looking at these trials, right? One very interesting thing about the registry, which I found, was right now, there's only one randomized trial looking at MitraClip versus surgery, right? That's Everest 2. The other kind of big trials were comparing MitraClip versus standard therapy, and in the U.S., clip is only approved for patients who are prohibitive risk. But going back to that registry, the average age of the patients was 73. The average STS score was 5, and as you noted, the replacement was 90% in a patient cohort that was probably a large percentage of DMR cohort that should have had the valve repaired. So what you're looking at is, again, talk about that creep again. You're having a relatively low risk cohort, right, that subsequently get a clip, and then they get, if it fails, they get 90% of them get a mitral valve replacement. And then one of the questions you ask is, why do you get a replacement? I've actually done a reasonable amount of MitraClip explants, and the reality is it's nearly impossible to repair the valve. It's very hard to repair the valve because the clip gets entangled in the chordae, and once you repair it, when you resect that clip, you're taking out a big chunk of leaflet. So it is hard to repair the valve. A small percentage of patients are able to. One last comment too, I think is really important. The average STS score for the cutting edge registry initially was 5.5%, but if patients had a clip explant, the 30-day mortality was 15%. So the mortality after clip was higher than the initial STS score. The same thing with the TAVR explant, right? So the TAVR explant, the initial STS score was roughly 5%. The in-hospital mortality, if you had an explant, was 9 to 16%. So again, the function of having these explants afford you a higher mortality than your initial STS score. Again, we can talk about whether or not that's a fair conclusion, but that's the data. That's what we're seeing: initial STS score and subsequent mortality after you get these explants.
Okay, perfect. Thank you very much.
Thanks again, Tom.
Thank you. Thank you, Dr. Steve.
So, and the final part of this discussion was already creeping into the mitral valve, and we go on with this topic. You know that our surgical solutions for the functional MR are not perfect, but there is a lot of techniques that show up, and Dr. Arai from Tokyo will talk about that.
It is my great honor and privilege to have an opportunity to make presentation in EACTS meeting. The title of my presentation is Mitral Valve Repair for Functional MR, Tailor-Made Approach. There is nothing to declare. 2 years results of CTSNet trial in severe ischemic MR comparing repair and replacement showed no difference in mortality and MACE. But MR recurrence was remarkably high in repair group. In this study, repair was only downsized annuloplasty. Subvalvular procedure was not performed. One of the problems of downsized annuloplasty is augmented posterior leaflet tethering, which is the main determination of MR recurrence. Especially left ventricular dimension to ring size mismatch has big impact on MR recurrence. Another issue of downsized annuloplasty is functional mitral stenosis. After downsized annuloplasty, dynamic deterioration of mitral inflow gradient is pointed out during exercise test. So, ring alone cannot solve the problems of functional MR. In addition to annuloplasty, subvalvular procedure should be considered. Second caudal cutting is one of the solutions. This technique is introduced by methods in animal experiment and have been performed clinically in some selected cases. This is a severe ischemic MR case to whom we performed second caudal cutting in combination with multiple CABG. In the left lower movie, you can see the dimple of the secondary chordae, which was divided and semi-rigid ring was implanted. Postoperative course was amazing. 1 year later, left ventricular function recovered to nearly normal level. I operated this patient more than 10 years ago. Now he is still very nice condition. He can run and his ventricular function is further improving. Why this case was so successful? Tethering pattern of this case was symmetric, so that second caudal cutting was effective to control MR. Elimination of MR in combination with complete revascularization to the viable myocardium must have induced this remarkable reverse remodeling. But the situation is different in case of asymmetric tethering. When regional lateral wall remodeling exceeds, lateral displacement of papillary muscles induce posterior leaflet restriction, leading to shoot prolapse of the anterior leaflet and eccentric MR jet in the direction of posterior annulus. For asymmetric tethering, one of the effective procedures would be papillary muscle approximation. This technique is effective to move laterally displaced papillary muscles to the center of the left ventricle, but its effect is mainly limited to lateral displacement. To correct longitudinal displacement, different techniques should be considered. Papillary muscle relocation is another surgical solution. This technique is originally introduced by Irvine Krohn. His original technique is to relocate only posterior papillary muscle. We modified Krohn's technique so as to relocate bilateral papillary muscles in the direction of posterior mitral annulus. We published this technique 12 years ago. Initially, we've got good impression of our new technique, but we encountered the following problem. This is a case of severe ischemic MR. LVDD was 74 mm and the ejection fraction was 25%. Preoperative echocardiography showed asymmetric tethering with eccentric jet. Under beating heart, after rigid ring implantation, posterior papillary muscle was relocated, but its effect was limited. Then, anterior papillary muscle was relocated. With this bilateral papillary muscle relocation procedure, satisfactory leaflet coaptation was obtained, and mitral regurgitation disappeared almost completely. This is the comparison of the relocation effect. Left side is preoperative MR, and the right side shows perfect coaptation achieved by this procedure. This procedure controlled mitral regurgitation quite well. But what is the role of papillary muscle relocation suture? Is this really suspending the papillary muscle, or just pushing down the posterior annulus towards the apex? Actually, Doppler echocardiography showed inflow mosaic color during diastolic phase. We induced functional mitral stenosis. Anterior leaflet opening angle was restricted, so we doubted ourselves that we might have applied wrong procedure. This is what we thought. When tethering is symmetry, whether it is anteriorly or posteriorly, direction of papillary muscle relocation doesn't make much difference. But when tethering is asymmetric and papillary muscle is displaced more laterally, relocation direction to the anterior annulus might be more reasonable. Depending on these hypotheses, we revised the direction of relocation from posterior annulus to anterior annulus, expecting better diastolic filling. This is the result. Left side is posterior relocation, and the right side is anterior relocation. In posterior relocation, leaflet opening was restricted, but anterior relocation provided almost full opening. As for MR, both procedures were quite effective. 6 years ago, we published these results. Red line is the change of anterior leaflet angle in anterior relocation, and blue line is posterior relocation. Anterior leaflet opening angle was significantly improved in anterior relocation, but it was deteriorated in posterior relocation. This is the mechanism. Relocation suture in the direction of posterior annulus pulls papillary muscles towards posterior annulus. At the same time, this relocation suture is pushing down the posterior mitral annulus towards the apex. This induces a mitral annular tilt effect, leading to restriction of anterior leaflet opening. On the contrary, when the papillary muscles are relocated in the direction of anterior annulus, the distance between anterior annulus and the posterior and papillary muscle is shortened, and the diastolic tethering of the anterior leaflet is relieved. Consequently, anterior leaflet opening improves. This is a summary of the effect of two different relocation directions. Comparing to posterior relocation, anterior relocation provides significantly better leaflet opening, but we don't know how this difference influences the long-term outcome. So we analyzed all of our patient group. There was a significant difference in survival with regard to the anterior leaflet opening angle. 2 years survival is significantly better when anterior leaflet opening angle is more than 41 degrees. It looks like anterior leaflet opening is the matter. This is our current strategy for surgical treatment of functional MR. If tethering is limited and expected to be a responder of annuloplasty, we simply implant downsized annuloplasty ring. If tethering is severe and posterior leaflet closing angle is less than 45 degrees, this is classified as symmetric tethering. Then, combination of annuloplasty and second caudal cutting is recommended. If posterior leaflet closing angle is more than 45 degrees, this is asymmetric tethering. The combination of annuloplasty and bilateral papillary muscle relocation exclusively in the direction of anterior annulus should be applied. We believe surgical treatment of functional MR should be individualized according to the severity and pattern of the tethering. Therefore, we recommend tailor-made surgical strategy for the treatment of functional MR. Thank you.
Thank you, Dr. Arai. That was a fantastic overview of what is possible in functional MR and how specific the repair techniques can be. How do you feel when a lot of those valves nowadays are simply treated with a clip?
Yes, the main problem of the clip is the possibility of the mitral stenosis. Actually, so not only one clips, they implant more than 2 or 3 clips at the same time. And there is a report from JACS. It's after procedure, if the mitral valve inflow pressure gradient more than 5 millimeter mercury, the long-term outcome is not so good. So I think the better solution by surgery is that we can preserve much better valvular function, not only eliminating the mitral regurgitation, but also control the mitral, avoid the mitral stenosis. I think it's a very important matter.
Okay. Please, Matthias.
Yeah, sorry. Technically, I'm interested. You have a vast experience in these subannular techniques. Did you ever encounter problems with the papillary muscle, a tear, a rupture, or something like that?
We started this procedure more than 10 years ago, and so far we don't see such a kind of a problem of the tearing of the papillary muscles. So when I started this technique, I'm really concerned about the tearing over the long-term result of the papillary muscle. But I think so far we precisely follow up the patient by echocardiography. We don't observe any tearing of the papillary muscles, fortunately.
Okay, thank you. So of course, I cannot comment technically, but I'm really amazed by how elegant and how many techniques you have to tailor the treatment for the patient with a failing ventricle. Of course, the edge-to-edge transcatheter repair is only a clip. I wonder, maybe I can ask you what you think of the clip when it is coupled with the transcatheter annuloplasty. Do you think the results will be better, or do you see the same challenges?
Yeah, and in combination of the annuloplasty and ring must be good, but the problem is if you put a ring in that kind of transcatheter procedure, the ring is a flexible band. But the Dr. Michael Boga already showed the comparison of the two different type of the rings. The rigid ring, good result, but the flexible ring doesn't work. So if you do a transcatheter procedure, the ring you implant should be a kind of rigid one. So the rigid and remodeling ring, it can correct the septolateral length. It's another important issue.
Okay, and from my perspective, I must also acknowledge that sometimes these patients with failing ventricles are treated with the transcatheter technique simply because they are declined surgery. So sometimes simply they have a few options left. But in your hands and people like the ones who are attending, of course, many patients may be offered the surgery also, although they have a failing ventricle. So it's very important to be aware that in good hands, you can achieve good results as well.
So I think the heart team discussion is very important. So the start point is a heart team discussion. If the patient is capable to accept the operation, so the surgeon have a lot of this kind of armamentariums. So if you have a good surgical team, you can choose much better choice for the patient.
I agree. You have more options. Okay, thank you very much, Dr. Arai. So we are perfectly in time for the last presentation. Matthias, if you agree. So we'll introduce another important piece of science, and it comes from Dr. Girdauskas, who will present the Reform MR Registry, pivotal initial results on the standardized subannular repair for treatment of secondary mitral regurgitation.
Dear Chairman, dear colleagues, my name is Valdis Girdauskas from University Heart Center, Hamburg, and I'm happy to present today our initial results from multi-center prospective Reform MR Registry, which was specifically dedicated to evaluating the outcomes of standardized subannular repair in the treatment of secondary mitral regurgitation. As you all know, the treatment of secondary mitral regurgitation is still controversial. An isolated ring annuloplasty in secondary MR is frequently associated with a high recurrence rate, while mitral valve replacement results in increased variability, morbidity, and mortality. Subannular repair by means of bilateral papillary muscle repositioning has been developed to improve the stability of mitral valve repair in the setting of secondary MR and demonstrated very promising results in multi-center studies. Reform MR is a single-arm, prospective German registry which aims to evaluate the reproducibility and safety of standardized subannular repair in a multi-center setting. We included all patients with secondary type 3B MR with left ventricular ejection fraction less than 50% and their started diameter above 55 millimeters and attending of anterior posterior mitral leaflet. We included the patient with degenerative mitral valve disease with an isolated ring dilatation and those undergoing simultaneous aortic valve surgery or redo surgery. A total of 6 high-volume German cardiac surgery centers participated in this registry and recruitment period was from July 2018 to July 2020. were able to include 71 consecutive patients with secondary type 3B mitral regurgitation. Here are demonstrated with 6 German centers that participated at our registry. A total of 71 consecutive patients were included and underwent a standardized subannular repair, which included bilateral papillary muscle repositioning in combination with a true-sized annuloplasty using an etiologic ring. The primary endpoint of our study was a freedom of more than mild residual mitral regurgitation, and the secondary endpoints were survival, freedom from MACE, and mitral valve reinterventions. Echocardiography data were systematically evaluated by Echo Core Lab at University of Kiel. Here shortly demonstrated the standardized subannular procedure. 240 Goretic sutures were positioned in both trunks of the papillary muscles and advanced behind the posterior mitral leaflet from the ventricular to the atrial side through a posterior aspect of the annuloplasty ring. Then the left ventricle was filled, the saline and the tenting was induced. A stepwise traction was applied to both Goretic sutures, which brought up the coaptation line to the level of the annuloplasty ring and corrected the tenting. The same procedure was performed at the level of posterior medial and anterolateral papillary muscle. Regarding the baseline characteristics, these were demonstrated a typical patient cohort presenting with secondary mitral regurgitation. Majority of patients had severely reduced left ventricular ejection fraction of average of 35% and diastolic diameter of 62 millimeters, with severely increased mitral valve tenting parameters and a resultant STS score of 3.2. 1/3 of the patients underwent an emergent or urgent surgical procedure, and most of them required simultaneous surgical procedures, while CABG surgery was the most common, required in 60% of our patient cohort. Mean annuloplasty ring size used during the procedure was about 30 millimeters, and intraoperatively by intraoperative TEE, no patient had a more than mild residual MR. Regarding the postoperative complication, the complication rate was very acceptable for this high-risk patient cohort. The most common complication was acute renal failure, which occurred in about 10% of the patient cohort. Of note, there was no perioperative stroke in our patient cohort, and the mean length of the ICU stay was about 3 days. One patient died during in-hospital course, most probably due to arrhythmogenic disease shortly before his hospital discharge. At the discharge echocardiography, there was no significant change in left ventricular geometry as compared to the baseline parameters. However, the majority of patients had none or only mild residual MR in 93% of cases, with very acceptable transvalvular mitral valve gradients and significantly reduced mitral valve tenting parameters as compared to the baseline values. So, summarizing these initial results from our registry, we can conclude that standardized subannular repair by means of bilateral papillary muscle repositioning can be safely and reproducibly performed in a multi-center setting. Our results show that bilateral papillary muscle repositioning with simultaneous annuloplasty results in very satisfactory in-hospital results and low prevalence of residual MR greater than grade 1. Although no major changes in left ventricular geometry occurred directly after the surgery, stenting parameters were significantly reduced after the subannular procedure as compared to the baseline values. Longer follow-up of our study cohort is required to confirm these preliminary findings. Thank you very much for your attention.
Yeah, thank you, Evalga. You see, I'm frozen right now because your presentation was so great.
Yeah. So maybe while you unfreeze, maybe I can start. Thank you very much for the presentation. I have actually two questions, which are again cardiologist curiosity. The first one is what is the added duration of a procedure if you perform this subannular repair on top of the leaflet repair? And the second question is which kind of data you would like to see to be reassured about the safety of this procedure and its efficacy? Do you want a control group or do you want the longer term data, more patients? So I let you reply.
So sorry, the first question was regarding the duration, how long we are doing this procedure?
No, the question was, okay, what is the added length of the procedure once you perform this kind of a standardization of the subannular repair? So is it something that costs extra time too much, or it's something?
Okay. I see. Actually, I think one of the real advantages of this technique is that you don't need a lot of time. If you experience and do it on a regular basis, so it takes for me about 5 additional minutes to, in addition to an annuloplasty ring procedure. So for isolated mitral valve repair, if you combine this with an annuloplasty, the cross clamp times are really very acceptable, much less than 1 hour. So it's basically this procedure does not add a lot of ischemia time for the heart, which is obviously mostly quite sick, in these patients. So I think it's one of the benefits as compared to another techniques where a lot of subannular techniques, which is much more complex and takes more time to implement.
Okay. Thank you. And the second question was more about what next for this technique, because you were very balanced and said that these are initial results. So my question was, what do you want to see in order to be more confident in proposing this to your patients? Do you want to see longer term data or a randomized trial or more patients?
Yes, so the aim was to include 100 patients, consecutive patients in this registry. So this is what we are doing now to complete the recruitment, and the aim of the study was to follow these patients at least for 2 years postoperatively. As you know, the majority of recurrences after this kind of procedure, after correction of ischemic MR or secondary MR, of course, not directly after the surgery, because it's the recurrences comes back. The mitral valve starts to leak at 6 months, 1 year after the surgery. If you look at the study by Acker, the recurrence rate at 2 years was about, I think, 50 to 60%. So that's what we want to show in this study, that subannular procedure improves the follow-up results, because the majority of these patients start to develop recurrent MR after isolated annuloplasty later on.
Okay, thank you. Matthias, welcome.
Yeah, I'm unfrozen again. Evalga, maybe one final question. Maybe you saw the presentation of Dr. Arai.
Yes, I do.
For the moment, it is surely better to stick with reproducible, the same technique always in your registry. But what do you think about his style of taking the opening angle into account and placing the sutures through the anterior annulus?
Yes, Matthias, it's a very good question. I was thinking about this because I always get this question, during the conferences. And I can understand the technical part. It's only mechanics. I think it is an option. It might be an option to perform repositioning procedure towards the anterior annulus. However, I have to say, although the opening angle probably is smaller in the posterior repositioning procedure, but in terms of a functional result, and we looked actually very carefully at the diastolic function of the left ventricle. We looked at the gradients. We did even a stress echocardiography. From functional point of view, we did not see a lot of mitral stenosis, I have to say. So I started to do this procedure, I think, 4 or 5 years ago, but I do it in the same way. I'm still performing in it. I think it's a procedure which develops and will be modified over time. But at this step, I try to stay, just keep the same technique in order to get the results for one procedure to see what happens at the long term. And from functional point of view, I do not see a lot of mitral stenosis at the moment.
Okay, thank you, Vargas. Okay, Davide, do you want to wrap up?
Yes, thank you very much for the invitation, first of all. Very instructive, and I think we have seen important data from 3 ongoing registries that really are complementary to the knowledge that we are getting from randomized trials. So we know not only about the indication, but also about the natural history of some of the techniques that we reserve to appropriate patients. So thank you very much, Matthias, for having me to co-host this event. Thank you to EACTS, all the speakers, and of course, all people in the audience for watching this session. Thank you.
Thank you and good night.